and I've had the pleasure of meeting this group of pulmonologists who have um, joined this course of Essentials of Palliative Medicine for Pulmonology on a prior session. I'm very happy to meet all of you again. Um, so apologies in advance that uh, some of my slides apparently didn't get saved. And what I will do is I will just go over some of the cases that I wanted to discuss with you. And I'll share some material um, with Pallium India to distribute to all of you about end-of-life care. But let's go over some of the um, guiding principles that we follow with end-of-life care. So by this time, I know that you've all been through a fair number of sessions where we've discussed about the need for palliative care in patients with chronic respiratory disease. What is palliative care for people with chronic respiratory disease? What is the symptom burden that patients go through? I think you've had lectures on managing the symptoms with opioids so that all of you are a lot more comfortable now with the use of opioids in palliative medicine. And we'll move on now to what happens when a disease progresses despite all our best efforts, and the patient is truly coming to the end of life. Early on, you would have seen about how the scope of palliative care starts from the point of diagnosis, goes through the time when a disease might be still amenable to treatment, and there is a curative um, um, a curative intention. But if the disease progresses, then the palliative measures will then supersede the curative intention. And then you have a point where the patient is now in the terminal phase of the illness, and that's the end of life care part of it. Then comes death, and then there's bereavement. So today we will be speaking about that very last phase, which is end of life care. And we make a clear distinction between palliative care and end of life care. End of life care is when we know that the patient inevitably is moving towards their death. So it's a very important part of our interactions with our patients and their caregivers. Dame Cicely Saunders, who you all know now, is the person who came up with all the guiding philosophies through her years of work as a nurse, as a doctor, and as a researcher. And one of the most powerful statements that she gave on to the palliative medicine community to keep in mind as we carry on our everyday work is that how people die lives on in the memories of those who live on. So the manner in which we die, it affects not just the patient, but also the people who are with that person at that time, at the time of death. And therefore, it's very important because in palliative medicine, it's not just the patient that we're taking care of, we're taking care of the patient and their caregivers and the family unit which is around it. So it's not just patient-centric, it's also family-centric, it's community-centric care that we are providing for our patients. Now, if I ask any of you to think about what do you think would be a good way to die, a lot of people actually surprisingly say that I just want it to happen suddenly. And I say the word surprisingly because people who choose that option sometimes have not contemplated of what it is like for those who are left behind if they die suddenly. If you know anyone in your circle who has lost someone, a loved one, to sudden death, one of the greatest regrets that they are never able to overcome in their life is a lost chance to say goodbye, is a lost chance to make amends for things. So sudden death happens only in about 7% of people in those who die. A terminal illness, which is diagnosed and progresses rapidly, may happen in up to 16% of people. Very often, that kind of terminal illness is usually associated with cancer or some very rapidly progressive neurological problem may cause that. Most of us will have the kind of death where there is an organ failure or maybe two organ failures, where there are ups and downs in the trajectory. Some will live on to old age and have frailty and very slow decline in all organ functions and deaths. When we look at pulmonary diseases, with pulmonary diseases too, the trajectory, it can be a rapid decline when it is something like a malignancy which is diagnosed late. or it can be a slow progression when you have a chronic lung disease, asthma bronchiectasis, a COPD, and ILD with exacerbation. So these are the kind of trajectories that we may have as the roads leading to death. And it's important that we know that these are the possibilities. So we're talking today about end-of-life care, but I also want to touch upon a topic which we all again need to be aware of, which is that therapies in the modern day and age are such that a patient will possibly, some of them, a small percentage of our patients will live on with advanced disease for a long period of time. And this is something we've spoken about earlier as well, that patients with COPD will live on with a lot of symptoms. But here I'm talking about something else. I'm talking about a person with a stage 4 lung cancer who knows that they have stage 4 lung cancer, who is on targeted chemotherapy or on immunotherapy, who may live for 3 years or 5 years on that therapy. Or it could be somebody who has severe COPD or ILD, who then gets a lung transplant and is now living on with lung transplant on medications, having exchanged one disease for another and living on with survivorship. So today, I just want to broach this topic of palliative care in survivorship, where you have someone who's on maintenance chemotherapy, which is going to go on lifelong. They are never coming off chemotherapy. They are living always with the knowledge that they have stage 4 cancer. That's a very different group of people. Or you have the kind of patients who are in the post-transplant population, where they are living on knowing that there is a limited amount of time, and after which there will be some complications associated with transplant. We know that they do go on to develop bronchiolitis obliterans eventually, or some form of, allograft dysfunctions. So these are patients who also require palliative supportive care in survivorship. Today, we will focus on this end of life, terminally ill, terminal care period, which happens when you're saying life expectancy of years. Now it comes down to months, weeks, and days. So this is the transition phase that we are going to be working on today. At this point, it's very important to understand and know our patients. So these are the important questions here. It is not what is the matter with the patient. It's not so much the physiology, the pathophysiology of the disease, but getting to understand what the patient's values are, getting to understand what the family's hopes and concerns and worries are. So these conversations have to start when we start anticipating that this patient is declining. And it's important to recognize that shift in the trajectory, which I mentioned in the previous slide, the transition, when it comes down to months, weeks, and days. In the era before 2018, and I will even say before 2023, when we had a much more favorable Supreme Court decision, decisions around end-of-life care and life-sustaining treatment were very complex, especially in patients with chronic respiratory disease, because the kind of support that was offered to them, invariably they landed up in ICUs. And we've spoken about this before, about how it is sad that a large number of patients with chronic respiratory disease end up dying in hospitals, end up dying in ICUs, end up dying on life support systems, even though it's an expected death. So now we have a much more robust system and documentation and guidelines, which helps us to provide medically ethical and humane and legal end-of-life care, whether the patient is at home, in the hospital, or in the ICU. And we'll discuss a little bit further about it in the course of today's talk. So fundamentally, it comes down to prognostication, to being able to say that, okay, my patient has only a limited amount of time left. Now, you know that we're going through this period of climate change where it seems like the vagaries of nature and climate change hit us completely unexpectedly. Even though we have scientists who are looking at weather patterns around the world, there are still times when cyclones and storms hit us and they catch us unaware, and they lead to significant destruction and distress to entire communities. So you've probably seen visuals in the news right now of Cyclone Ramal, which has made landfall in West Bengal and parts of the Northeast. And you have seen floods in Manipur, in main roads looking like they are rivers, hospitals having to be evacuated. So it's really important that we try and be as good at our prognostication in our patients with chronic respiratory disease, because the amount of distress that the entire ecosystem that the patient lives in, the patient, caregivers, everyone goes through, it is nothing less than a cyclone hitting that family if they are not prepared for what is coming. So this is just a reflection on how things have changed, even in the world of official professional pulmonology bodies, where the ATS in 2010 made a statement about how palliative care should go hand in hand with curative restorative care, and actually expanded to saying that even in the ICU, the same thing, curative restorative care and palliative care go side by side. And when there is impending death, if it is an expected one, then the patient should be referred to hospice if possible, and the patient and family supported through death and bereavement. In the situation of ICU, if there is death in the ICU, again, palliative care up to the point of death and support to the family in the time of bereavement. Now the ATS in 2024, in 2022 made this latest statement where they've given us very, definitive points in the trajectory of different illnesses, whether it is lung cancer, whether it is COPD, whether it is pulmonary hypertension. There are certain points in the trajectory of illness which present as opportunities for us to talk about values, about advanced care planning. So I can understand that things can be unexpected in some patients where it is the first hospitalization is directly a severe pneumonia. There was a background ILD that we did not know about. This patient ends up directly going to the ICU, intubated, difficult to wean off. Those kinds of situations, there isn't time. That's that storm hitting you without any idea. But in most other patients, there will be ups and downs. And each of these ups and downs provides us with an opportunity to initiate conversations which help us to understand what matters to that patient. The image that I had shown you earlier of that gentleman, I'll just go back to it, sorry, so that I can just tell you the story of that gentleman. This is a gentleman who had severe COPD, who had had exacerbations a couple of times and hospitalizations. And this picture is taken from Dr. Wes Eli, who is someone who works a lot in the area of palliative care in ICUs and specifically with patients with respiratory disorders. So this gentleman had COPD. He ended up on a ventilator in his third exacerbation, intubated, difficult to wean, tracheostomized, unable to wean off the ventilator despite this. And he'd spent about 3 to 4 weeks in the ICU. And he said that I do not want to continue in this state anymore, and I would like to stop the ventilator. He wanted to forego life-sustaining treatment. His wishes were, take me off the ventilator, keep me comfortable, let me be holding my wife's hand, and let me have one cold beer before I die. And this is what the ICU team arranged for him. They gave him opioids. They had him on morphine. His wife was holding his hand. He got his last beer, and slowly over the next 24 hours, his breathing slowed down and he passed away peacefully. So this is the importance of being able to have conversations, knowing the patient and being in charge of how the manner of death happens for the patient. So fundamentally, it comes down to when, what, where, and how. That is the process that we are looking at in end-of-life care. The surprise question is something which is, we look at prognosticators in different diseases, right? We look at a gap index in ILD, we look at board, we look at different kinds of predictors which help us to understand severity of illness, and how the patient is doing or declining on that trajectory of their illness. One of the things that's been found to be very effective and useful is the surprise question. The surprise question is, would you be surprised if this patient were not to make it through for one more year? So I have a patient coming to me in the OPD. They are someone I have been seeing for the last 2-3 years. They have been hospitalized 3 times in the last 1 year. The previous year, there was 1 hospitalization. Last year, there were 3 hospitalizations, of which the last 2 hospitalizations have been in the last 3 months, right? So we have an increasing frequency of hospitalization. We have a reducing interval between hospitalizations. This patient has also developed some amount of heart failure and pulmonary hypertension, has been oxygen dependent for the last 3 months after that second hospitalization. Now, if you ask a person who has been seeing this patient for the last 5 years, would you be surprised if this patient were not to make it through for one more year? And the answer is no, I would not be surprised. This patient is at a high risk of death in the next 1 year. Then we know that this is a patient where we need to start having the conversations on advanced care planning, trying to understand what are their thoughts, their values, what are their fears and concerns. And what are these fears and concerns and thoughts that we want to explore? The big what that we don't speak about is death and dying. Those words are words that we don't like using. We don't like saying death. We don't like saying die. We don't like saying dying. And I understand, because fear of death is a very fundamental, deep, visceral, natural reaction in all of us. And conversations around death bring fear, right? So it is important that we learn to address that fear within ourselves of using those words. And yes, you might euphemize it. You might say that things are getting serious. But at some point, especially for the patient and family who is intelligent and open to a conversation, it is important to use those words. They sometimes express relief that someone has given them a safe space to talk about this. Okay. So addressing death and dying often is, we wonder how to broach the topic. And the answer actually is to just ask the patient, have you ever wondered, what if next time it is more serious than last time? So, last time was very serious. You were in the ICU for 7 days. You were in the hospital for 2 weeks. You're meeting them in the OPD now. And you say, like, how are you feeling now? How was that for you? And they'll tell you it was horrible. They'll tell you, I was in the ICU for 7 days. And those 7 days, I saw so many things. I never want to go there again. So that gives you the opening. So what do you think? Is this all worth it? Is this how, if you think about all of us have to go one day, what should it be like? And then they tell you what they would prefer. And they will usually say, I just want to go in my sleep and all of those things. And then again, you can have this opportunity to start that conversation about, oh yeah, but that may not happen. So sometimes if we know and if we're planning and talking about it, then we know it can be the way it should be according to what you believe, according to your values. Some patients will be open to the conversation, some will not. And if a patient is uncomfortable, there is no need to push the issue. Then we can, but at least it behooves us to open that conversation. When a patient is agreeable to it, so you ask them, are you comfortable talking about this? If you're not, it's okay. If ever you want to bring it up again, this is a safe space for you to have a conversation. No subject is off the books. You can speak with me about anything. That is the safe space you have to create with the patient and you, and the family caregiver and you. The question of where and how. Does a person want to die at home? Is it difficult for them to be taken care of at home? There might be just logistics issues. They might be living in a space which is, there is no elevator in the building. It is difficult for the family. The space is not enough for the equipment they might need. Or if a patient is suddenly got admitted for any reason and did not really wish that, are they okay with the ICU or the hospital? Are they in a position to make the decision, or is it the family caregiver who will make the decision? So these are all possibilities that we must keep our minds open to. And one very important thing is, when we are having a conversation with patients about this, it is important not to project our values, our ideas of what a good death is. Our goal is to explore what they want. There may be religious beliefs, or just their belief of, what is being a fighter, something like that, which makes them make certain choices. Our job is to have an open conversation, be aware of what their wishes are, present all the possibilities to them, allow them to make their choices. Maybe guide them to choices which are less distressing, but not project our values onto them. When it comes to how, that is where the question of foregoing life-sustaining treatment comes in, and having that conversation about assisted life support, using the word life support. Very often when they think of it as intubation, ventilator, some of these patients are already on oxygen and BiPAP. So they think of it as a natural extension of that. But how do we differentiate it? It's not just a breathing aid. A ventilator becomes life support. So that is a much more evocative term, helps to explain the severity and the criticality to them better. So if they have certain decisions about no ventilator, no dialysis, no surgeries, those are the kind of possibilities that we need to explore and discuss with them. Then we come to recognizing the active phase of dying. So some of our patients will go through multiple exacerbations, and this is one of those things that really makes prognostication and respiratory disease very difficult, because some of our patients will have multiple exacerbations and go in and out of the hospital. They're like a cat with 9 lives. They'll come out of each of those situations also. So it makes you also very hopeful, it makes the patient and caregiver also very hopeful, because they come so close to the brink and then they slowly pedal their way back. So recognizing active phase of dying can be tricky, but there are certain signs which tell us that that is happening. So when a patient moves from this palliative care to end of life care, and from end of life care to active phase of dying, what ends up happening is the patient's energy for engaging in anything else starts coming down. So the family might come and tell you, I just want to talk to you, doctor. I want to come to your OPD and talk to you because father has just got no energy at all these days. He just sleeps all day. His oral intake has come down. He doesn't even speak anymore. He's just lying in one place. Okay, so the energy starts waning. All their energy is just survival. So they start eating less, they start speaking less, they start sleeping more and more and more. It's not like they're unarousable, it's just that they are that exhausted. So when that is one of the ways that we can recognize the active phase of dying. So if that is happening in a patient who you know and have recognized from the surprise question that this patient is going down, their oxygen requirement increases. If you've already got them on opioids or benzodiazepines for breathlessness, their requirement of morphine starts increasing. Earlier, they were okay with the breathlessness being managed with 5 to 10 milligrams of morphine twice a day or thrice a day. Now you're having to give it every 4 to 6 hours. So it's coming to that 5 milligrams every 4 hours you're needing to give it. So that tells you that this person's symptom burden is increasing, they are getting sicker. So you speak with the family and tell them that things are going down, and right now, the focus should really be on keeping them as comfortable. When it comes to keeping them that comfortable, we Indians have a very close relationship with our idea of caring, caregiving, taking care, loving with food. So if someone is not eating or drinking, it is very distressing to family. And very often, they also associate food with, if they won't eat, I can't give them their medicines. So it's important also to counsel them at this point that if oral intake is going down, that's fine. The way I tell them is, think about it when you have a bad fever and you don't feel like eating anything at all. And if somebody gives you something, you feel like throwing up and you feel more distressed by it. So that's how this person is feeling. Giving them food, force feeding them, emotional blackmail, you have to eat orals, those things are more distressing to that dying person. So teaching the family to avoid doing that. Thirst is a natural thing. So as long as they are able to consume liquids, we try to keep up with oral liquids. If they're finding it difficult to swallow, that as we progress on the active phase of dying, they find it difficult to swallow, then we tell them to give really, really small quantities of liquids just to moisten the mouth so that the sensation of dry mouth, all of that goes down. At this point, the patient may have many different symptoms, and we'll address some of those symptoms as well. When it comes to that terminal phase or imminent death, usually the dying person, is in a state of sleep, not arousable, altered, is encephalopathic, but the breathing may change. You might see irregular patterns of breathing. You might see giant stroke breathing. And that is sometimes distressing for family members to watch. So again, preparing the family for what they may witness and what they have to support is important. So one of the things that I do is I sit down with the family member and tell them that, when things go down, this is how it might be. Sometimes there is delirium, sometimes there's confusion. So some people may have agitated behavior also towards the end of life. So preparing the family of what might come and how to manage it, if this is going to be someone who chooses to die at home, is important. So let's look at what are the components of a good death. Okay, there is a quality of death index, which is measured around the world, and unfortunately, India is ranked somewhere around. I don't know what the latest is. It probably there would have been an update in 2020 or 2022. From 2010 to 2015, we dropped from rank 48 to rank 67, and I can't imagine that we have climbed up the rank much. Fundamentally, the quality of death index across the world for all countries is if we are able to provide the supportive care for dying people. One of the measures of that is, did that person have good symptom control before death? And a very simple measure of that is how much of opioids are used in a country according to the number of deaths. So per dying person, how many mg of morphine equivalent was used, for example, would be a way. So when you realize that in that way, England is high up on the list of being a place which has a good quality of death index, because the National Health Services provides palliative care, including home hospice, including access to opioids. In India, probably Kerala tops the list, and now Telangana coming up, and Maharashtra and Karnataka also have access, but we have a long way to go because it's not part of the public health system yet. So how do we define what is a good death? These are the parameters that tell us that this is a good death. And if I think of it for myself, this is what I would define a good death as: to know when death is coming and to understand what can be expected. A lot of times people express a death wish when they are diagnosed with cancer or a life-limiting illness, like, I just want to die. Can't you give me something to die now? And why is it that they ask for death? It is not so much death that one is afraid of as is suffering. We're very afraid of being in pain and suffering. If I am told and reassured that there will be someone to take care of me, that my death will be dignified and on my terms, I will fear it less. The fear of the unknown is really what drives fear of death so much. So if I know when it might be coming, if I know what to expect, if I'm able to retain control of what happens, people doing things to me that I do not want, I would be frightened out of my wits. I don't want that to happen. To be afforded dignity and privacy, to have my sense of personhood, not have my body handled, my clothes handled without any control over what's happening to me, that would be offensive. So if I'm able to retain dignity and privacy, to have control over relief of symptoms, to have choice and control over where it happens, at home or in the hospital, to have expert care available around me, someone to take care of me, someone to take care of my family, to possibly have access to hospice care, to be in a quiet and peaceful place when I die, to have control over who is there next to me. I want this person here next to me holding my hand. To be able to tell the people I leave behind what needs to be done, the advance directives, to have time to say goodbye, to have access to spiritual or emotional support, to be able to perform any little prayers or any conversations that I might want to have. So these are the things that are considered the component of a good death. If we keep in mind that our patients have that trajectory where we are able to predict, at least to some degree, at least to the last few months, we should be able to at least deliver some components of a good death for our patients. And when I know that a patient has limited time and start having these conversations in clinic, I broach the issue with trying to think of the fact that, things are going down, and how does that make you feel? Your health is deteriorating. So I might have somebody whose PFTs are showing me decline, whose oxygen saturations are running lower, who's now breathless at rest. And I know that they are feeling, I said, how are you feeling? I know that physically things are not easy. what's going on in your mind. And sometimes they'll tell me, no, I've lived a good life. And sometimes they'll tell you, look, I'm really so, I'm such a failure. My child is still not settled and I didn't do this. So they need to be able to express what unfinished business is there and to help them close some of the unfinished business. For the family members and for the patient, if you are able to get good symptom control, then you have to tell them that each of those days, whether it is at home or it is in the hospital, is still an opportunity to make meaning, to derive purpose, and to make memories. So sometimes we encourage families to do things together, which will bring the family together and create a memory which is useful for them. So, you know, people will sometimes choose to have a prayer ceremony, people will choose to have a get together, you know. So, say there's a wedding that's happening in the family, and this person is the elder of the family, and um, the wedding is going to happen 3 months out, but I'm not sure they're going to make it. And this is their granddaughter who's getting married. I might speak to the child of the patient and say, you know what? Ask your daughter and her fiance to come and spend time with grandmother and have a little ceremony where she can bless them, because she may not make it for the wedding, but it's important for everyone there. So memory making, meaning making, winding up unfinished business, any financial and legal work that needs to be done, and accounts, uh, land deeds. There are so many things that need to be settled. Passwords, uh, to access for bank papers for spouses. This is a difficult one, but sometimes it's about making sure that certain transitions happen in joint accounts and things, and in terms of inheritance and families, that these are all settled beforehand. Spiritual concerns also are something that we need to address, because sometimes patients you manage to control their physical symptoms, but they're still in a state of distress. So this is actually borrowed from neuropalliative care, where again there is a decline in physical ability, and we are known in sometimes in those patients that they're going to lose their ability for speech as well. So it's important for us to address these while they still have the power of communication, because communication is sometimes lost in progressive neurological illnesses, to find out if they are at peace with what is happening, and if there are things that need to be done to help them achieve that level of, I have done the best that I can. In today's day and age, digital and social media accounts and passwords, and making sure that those are given to other people within the family, within the circle of trust, is another important thing. And the reason I bring this up is because we are now in a highly interconnected world. And caregivers of patients with chronic respiratory disease go through a lot for many years. So they're in the state of hypervigilance at all times, and their entire life is consumed by the care of the person who has that problem. If they don't have access to accounts of this person, sometimes there are other people who are reaching out who don't know the patient has passed on, who will send messages, who will put up things, and this leads to a lot of distress for the caregiver during the bereavement time. So we actually even teach family caregivers how to cope with that and how to send out messages, especially at the very end, wherever the end might be, whether it's at the home, in a hospice, or in a hospital, in an ICU, or in a hospital where we have created an end of life care hospice like situation for the last 1 week for the patient. If they want to die in hospital, if the nursing needs are high, we sometimes provide that. Then we help them to make broadcast groups on WhatsApp, so that the caregiver can then devote themselves to be fully present with the person. And it's just a morning update sent so that the entire family knows what's going on. Everyone is kept informed, but also there's a certain amount of space and privacy that's created for the immediate family. Now let's come to the what in the very last few days or hours before death. If your patient is in the hospital, I mean, in a hospice situation, it's very different, because in a hospice, the entire staff, everyone is trained to take as much care of a dying person as a person who still has months or years, right? In a hospital setup, sometimes when we know the person is dying, there seems to be a sense of abandonment. We stop spending as much time in that patient's room. We stop spending because I know this person is going to die in 5 days or so, like, just maybe a week or two at best. So am I just glancing through in my rounds? Am I spending enough time with the person? Am I spending enough time with the caregiver? Because their needs are different. It may not be a medical need immediately, but they need to feel that their doctor and the team is still paying as much attention to the person. Your assessment of frequency of things may change. Like I might ask my nurses to decrease the vital signs recording. I might tell them to not disturb them all through the night don't wake up for vital signs. Let them have their rest at night. But in the daytime, pay as much attention. You might choose to do things in a way that allows the patient and the caregiver rest. If they are sleeping, I will try not to disturb them. I will try to let them have their rest. But that doesn't mean I'd skip my round. My afternoon round, my evening round will still happen. But I'll go peep in and see when is it okay for me to spend time with them. Assess the patient fully, okay, and counsel the caregiver each time about yes. Because one of the important questions that come up is they'll keep asking you, so how much longer? So how much longer? And this is one thing that we have not figured out. Just like obstetricians, other than in C-sections, cannot tell you the exact time that a baby is going to be born, there is no palliative medicine doctor also who can exactly predict at what time a patient is going to die. So this is something which is almost impossible for us to predict unless it is a deliberate, when we know it is a withdrawal of life support, then we know that we can predict it to some degree. Okay. So even in the active phase of dying, it is hard for me to predict exactly when it might happen. I can say hours to 1 day, but I will not be able to say exactly when that might be, whether it will be 15 minutes from now or 6 hours from now. I will not be able to say that. And that does create some distress sometimes in families. Patients will experience certain symptoms more often than others in this situation. They may experience breathlessness, they may experience pain, nausea or vomiting may happen. They may have abdominal distress because of constipation or distension. If a patient has an airway problem like a malignancy or something like a central airway thing, they may experience stridor. If they have a malignancy, again, they may experience bleeding. So hemoptysis or bleeding from a wound may happen. And sometimes some patients may experience seizures. So, the way we normally think of treating any of these symptoms when we are in the curative phase is very different from when we are in the end of life phase. The breathlessness, pain, nausea, vomiting, constipation, you've already been through modules which speak about opioids, benzodiazepines, and all the non-pharmacological means that we address that with. When it comes to stridor, hemorrhage, and seizures right at the end of life, the most important drug that we use here is benzodiazepines for sedation. Because what we want to take away is the absolute fear and panic that comes at that time. So if I have a patient who's hemoptysizing and they are in end of life terminal phase, at that point, my drug of choice is not going to be anything other than midazolam. Because I want this patient to now, small boluses of midazolam you keep giving so that they are not experiencing that sense of choking while they're dying if they have stridor or hemorrhage. Same with seizures, benzodiazepines will be your drug of choice. Whenever we go and check on these patients, one of the things I always check on is their eyes, their mouth, their nose. They start developing dryness and stickiness and cracks. So I always ask the nurses to be very diligent about mouth and eye care. Skin care, they develop pressure sores easily, especially at the time of dying, just like the last few days. And their skin becomes so fragile that when we turn them, we have to be very careful because just the abrasion causes ulcers to form. So just very gentle with position change in any tubes that they have in their body. Just be very careful because literally the pressure of a Ryle's tube will cause ulcers to happen. So these are little things that we do which soothes the patient as well as the family member, shows them that we are taking extreme care of every little point of comfort for the patient. Just like we have the golden hour for strokes, the golden hour for antibiotics, the golden hour in trauma, the golden hour in any emergency, there is the silver hour in death and dying, which is the hour when death is imminent and the hour after, or the immediate aftermath of the death. Because sometimes we can actually make out, right? Because the patient is starting to brady down. Their breathing is becoming irregular. Their heart rate will be registering like in 50s and 40s and 30s, and you know that they are slowly going down. At this point, if we let the family members know that I think things are now going to proceed more rapidly, their blood pressure might be an 80/40 or something, they may be able to alert other family members who want to be there with the patient as they die. So this allows us to prepare the caregivers sometimes, and this is truly one of the most moving experiences that I have seen, is some patients and their family members have told me, we want you there holding our hand if you are in the hospital at that time. We understand if it happens in the night, you may not be there. But can you please hold my hand while I hold my father's hand and help him cross over to the other side? Now, if you can, um, be there to provide support for the patient and the caregiver at the time of death, nothing like it. If you can't, even if there is anyone in the team, if we let the nurses and the duty doctors know that at that moment, what we are seeking is calm. Don't call for a code. Don't create an atmosphere of panic. Let it just be peaceful. So even letting our younger associates and nurses know how to handle at the moment of death so that there is peace and calm and dignity maintained at that time. That's very important. In the immediate aftermath, there might be things that the patient may have expressed wishes for. This could be eye donation, arrangements that they need, the care of the body, how they need things according to religious or cultural beliefs. So the immediate aftercare is important. Making a safe space for the patient's family members, immediate family members, to be in a huddle together, maybe a space where they can even cry, right? Because sometimes it's in a crowded, it's not always easy. If we're in a general ward where there are 6 families in the same large room, but if it's possible to create one little room where the family, the bereaved family, can sit down, have space, and have your team around them to help them, give them time, give them time to deal with the immediate grief, and then helping them in any paperwork, expediting paperwork that's needed at that time. So that's what the end of life care part of it is for patients with chronic respiratory disease. I had a couple of slides, which I'm sorry, I seem to have lost those, but I'll just discuss 2 quick cases before we go on to the case discussion also and questions that we have. So despite our best efforts, sometimes things don't go well. I've had some patients where they have been with me for 6 to 8 years or even 10 years. And, when we get to that last 2 years where they're having frequent hospitalizations, that last 1 year where there's more happening, and in the last 1 month, and that very last hospitalization, if this is a patient who has a lot of nursing needs, they may choose to come and die in the hospital. So I've had some patient, one gentleman in particular, who was on BiPAP for almost 4 years before he died. And the last exacerbation, he went to the ICU, was on 24 hours BiPAP for about 4 days straight, could not come off it. And he said, I know this time I'm not coming out, and I know I don't want to be intubated or ventilated. So let's move to the ward, and I want to be around my family. And this patient had severe air hunger the minute you took the BiPAP off. So we started him on a morphine infusion. And I remember this very clearly because my fellows were very wary of me starting a morphine infusion because this patient's PCO2 was around 58 and his baseline was around 52 to 55. So at this point, with 24/7 BiPAP at 20/6, his PCO2s were running in the 58 to 60 zone. And I started the morphine infusion, increased it up to 1 milligram an hour, started off slow at half and then went to 1 milligram an hour slowly. And what happened with that, because he still had an arterial line coming out of the ICU, is 6 hours later, his ABG showed the PCO2 at 62, but his breathlessness was down and we were able to take off his BiPAP mask for an hour or 2 at a stretch. And that meant he could speak to family. That meant his wife could come and feed him his favorite halwa, just 1 spoon. Right? So these little things happened. It actually took another 36 to 48 hours before he passed. But in those 36 to 48 hours, he came off the BiPAP for enough durations of time where he was able to speak and interact with his family members. On day 2, his sedation became more. And on day 2 was when his PCO2 started rising. We weren't testing anymore, of course, but that's when he became more drowsy, more encephalopathy, and then passed away peacefully. So this was one of those cases where even the family member, when I was saying, let's take the BiPAP off and let's just give him oxygen, this family member had been taking care of him for so long. If he would come and if the nurse would check the pulse oximeter and say the saturation is 95, the family member would be, Dr. Bhatt, we need to decrease the FiO2 because, this PCO2 will rise. And at this point, I was telling him, I said, it is okay if the PCO2 rises because it's only going to help him not feel that breathlessness as much. But you see, he's coming off the BiPAP. He's still awake, even when the PCO2 is rising, and he's still able to interact with you. So for us, the goal over here was making sure that he got this little bubble of time with his family where he could interact with them. They were all able to be together, and he could die peacefully in a manner that he wanted, in the way he chose. Another patient, family member wanted it to be at home, but when the moment finally came and she suddenly developed severe breathlessness, they panicked, they called for the ambulance. Now, in this situation, what happened was the ambulance brought them to the ER and the patient died in the ER. But this was chaos because it was a sudden change in decision. So the patient's family member had a lot of guilt at that time, saying that, oh, I shouldn't have done that. So the bigger challenge was supporting the patient's family members saying, no, it's okay. What you did was not wrong. It's all right. You still did not intubate her. She still managed to get a dose of opioids and benzos. And you were still there with her holding her hand. So it's not like she was abandoned in any way. There have been some patients whose families have been able to hold it together to have that home death which the patient had desired. But when they are not, we have to let them know it's perfectly okay. You did your best. Because the caregiver's bereavement support for patients with chronic respiratory disease is a huge component of end of life care. So I always schedule at least one meeting with the patient's family members after the death as well. In some patients, I feel I haven't managed to initiate opioids early enough. In some patients, I feel secretions were not addressed adequately. So over the years, I've realized that with our best efforts, there will be a few patients here and there where this good death may not be as good as we hoped for. As long as we did our best to try and make sure each of the principles of what a good death is are met, we have done our task. And then, of course, a very important part of supporting the family members. Family members often deal with a lot of guilt, especially if there is withdrawal of life support involved. Ethically, withholding and withdrawing life support are the same, as long as you also have palliative medicine on board. So anytime we are withholding or withdrawing a life-sustaining treatment, it is important to have palliative care on board with palliative sedation with opioids or benzodiazepines ongoing. The way to rationalize it for family members is, especially if you're doing withdrawing, is that you gave it your best and it still didn't work, and therefore it was time. So a time-limited trial, introducing them to the idea that even if one is not able to make up on one's mind about, okay, I still want to try the intubation, and what I propose is a time-limited trial. Let's give it so much time, like we did with our gentleman who went to the ICU for 4 days on BiPAP. So just because somebody is DNR, DNI does not mean no ICU care. It still means ICU care with a ceiling of care, this much and no more, with a time-limited trial, so that we try and fulfill the criteria of a good death. The patient retains control as much as possible of the manner in which that they will pass away. And with that, I thank you. And I'm inviting any questions, or if we want to move to case discussion, whichever way you choose.
Thank you, ma'am. Maybe we can start with the case discussion, and then followed by that, the participants can post their comments in the chat box. Once the case discussion gets over, we can take the questions. I think that would be fine, as it is 7:28 now. Okay. We have Dr. Srija ready for the case presentation today on end of life care. I welcome you, Dr. Srija, and it's over to you.
Good afternoon. My name is Dr. Srija. Hope I'm audible.
Yes, you
Yes,
are.
doctor.
Yeah. Now, currently, I'm working as a junior consultant at K Hospitals, Hyderabad. Um, okay. Coming to my case, is a young male patient who is of 30 years who was finally diagnosed with the Ewing sarcoma of left tibia and calcaneum post chemotherapy. He was having the post left below knee amputation. Now he has a pulmonary metastasis with a recurrent pleural effusion. This was a final diagnosis. And the presenting complaints were he came with the complaints of shortness of breath, which was MMRC grade 2 to 3, which was since 20 days, and complaints of fever since 5 to 6 days, and cough with expectoration since 5 to 6 days. And in this visit or in this admission, patient has difficulty in speech since 5 to 6 days. There was an loss of weight and loss of appetite was also there, which was significant. And the history of illness, if elaborating the complaints, the shortness of breath was MMRC grade 2 to 3, was gradually progressive, which was not associated with any weakness, no orthopnea or UPND, and fever, which was high grade, which was intermittent in nature, which was subsiding with the antipyretics, and the cough, which was associated with expectoration, which was white in color. There was no hemoptysis, no foul smelling, and nothing. And the weight of loss, loss of weight and loss of appetite was also significant during this course of admission. And examination wise, if we look at the vitals, we'll look at the during admission and what happened to his vitals during the course of this admission. So during admission, patient was conscious, he was quiet, he was dyspneic. His pulse rate was around 98 per minute, and his BP was 100 by 60. His saturations were a little low, 88 to 90% with the room air, but he was maintaining with 3 to 4 liters. With the nasal problems, he was able to maintain the saturations. And if you take the respiratory examination, there was a decreased breath sounds in the right infrascapular and infraaxillary areas. The radius was normal and CVS was S1, S2 was heard. So we can come to a thing that there was again having a pleural effusion, which was that, which was causing the distress, and that was the cause for causing this decrease in saturations. But during this course, patient was same conscious current, but it was more tachypneic. His pulse rate was increasing. It was 100 to 120, and BP was dropping. It was 90 by 60, and the saturations were also dropping, 86 with room air. There was a decreased breath sounds. During this course of admission, patient was refusing for IV fluids and earlier oxygen support. What was the treatment or the significant investigations we have done during this course was a PET-CT which was done, which was suggestive of hypermetabolic left lung lesions. There was mediastinal lymph nodes, which was showing the increased metabolic activity. There was right lung pleural deposits, right pleural effusion, and we could even notice that there was a brain lesions which were showing the activity, which means that there was even metastasis to the brain. An ultrasound chest was done. It shows that mass with a pleural effusion. And 2-day echo, which showed a severe LV dysfunction. There was a moderate TR, that is tricuspid regurgitation, and the moderate amount of even pericardial effusion was also noted. And there was a compression of the left atrium with the external walls. So we managed, actually the patient was managed on the palliative care. That is, he was given the injection gemcitabine, which was given in the low dose. And he was given the antibiotics like Magnus-4 during the course of admissions, Pantop, Dose, and Copstrips, other supplements, and even gave the IV fluids, nebulizations, as well as the oxygen support. What were the psychosocial aspects which we were concerned was actually the patient has in the span of 2 months, patient has 2 visits. We can notice a change in the patient prior to the last visit and this visit. When patient was there in the prior visit, he was very active. He was accepting all the treatments, all the medications, and he used to ask all the questions, all the doubts and everything. But in this admission, patient was into depression. He was not ready for any further investigations, further treatment or anything. We can notice that change in the person's, acceptance, and there can be a fear of death or impending death or a denial of death, might be into depression. And he was also worried about his wife and also the parents. So these are the medications during his course. It was the injection Magnus-4, which was 1.5 grams, which was given TID, and gemcitabine, which was given as a low dose. Darifalin, it was given on SOS basis, and the oxygen support. They were given IV fluids to maintain his BP and nutrition. The tablet Dodo for antibiotic for his fever, and he was also on tablet morphine for MG, which was given as TID basis. And all the supplements like Shelcal, Optiduril was also given, and cough suppressants was also given. Later, as the patient was not maintaining the BP, even the NORAD support was also given to the patient. So what was the main concern was there was a fast progression of the disease. which has a poor response to treatment because patient was diagnosed just a year back with Ewing sarcoma of the left knee, post chemotherapy and post amputation. But during the course of chemotherapy itself, patient has developed the pulmonary mets, which includes that is a very fast progression with a poor response to the treatment. And later we can notice that even the multiple organs like brain, lungs, and everything. And during this course, we have noticed even some sort of enlargements or some sort of deposits even in the liver. So multiple organ involvement is also there, which is making this prognosis poor. And patient was having the refractory shock. So coming to the summary of my presentation, that it was a very young male patient who came with Ewing sarcoma post chemo with lung mets as well as the brain metastasis, recurrent pleural effusions, and all the necessary investigations which was required for this was being done. The patient had a refractory cardiogenic shock as well as the cardiorespiratory arrest. CPR was done according to the ACLS guidelines to revive the patient, and we was connected to mechanical ventilator support. But after 1 day, we have lost the patient. So what were my discussion points to discuss was like what else could have been done by a pulmonologist, or what the palliative care or end of life care or support could have been given to this patient, and how to handle this type of situations, how better could have been handled both to the family as well as the patient.
Thank you for sharing this case, Dr. Srija. Heartbreaking situation I know this young man was in. Yeah, I'm actually not surprised that this was the trajectory and the course of how things went. So many questions coming up in my mind right now. One is how well aware was the patient of his prognosis? Because, there's one thing that you said which really struck me, which is that there was a marked change in the patient's attitude in the second visit. Patients, even without knowing what the reports are, even if the family doesn't tell them, they are the ones with the disease. They are feeling it in their bodies. They know when they're going down. In our practice setups, collusion is a very important issue. It could be that there is a wall of silence that starts off, which is patient's family is not telling the patient what the reports are. No, it's okay. Doctor said 1 more round of chemotherapy. Patient is not telling, I know my body is going down. I know the chemotherapy is not working. Patient is not telling the family is not telling the patient. In this, what ended up happening, all those issues of worried about my wife, worried about the rest of my family, worried about parents, worried about children, all those things were not addressed. We had a lot of focus on treatment of cancer, not as much focus on treatment of symptoms, right? So I saw that you had morphine 5 milligrams TID on board. A patient with Ewing sarcoma with mets everywhere, I'm pretty sure the pain was more severe here. So I think there might also have been a pain element, which probably was not adequately addressed out of fear of worsening respiratory issues. So this is a possibility. I'm not sure, but I do think that this patient might have had an element of pain that was not adequately addressed. So we know that in patients who have bony tumors, bone involvement, there's a lot of pain. So pain plus breathlessness needs whatever opioids you need for the pain, plus 15 to 20% more for the breathlessness. For the breathlessness, there's also a pleural effusion. We know that as pulmonologists, we know we can do, intrapleural catheters or pleurodesis is something to offer. So palliative procedures, I will still offer, even right up to end of life. I mean, right up to that last week or something, because draining out the fluid really does help them with their breathlessness if they have fluid which is contributing to the symptoms. And for the patient's family, if they knew and were prepared better for it, then this is a patient where with multiple organ involvement and refractory shock, being on NORAD support already is being on life support. So the decision of intubation and ventilation in a non-reversible, this is considered potentially inappropriate or / non-beneficial treatment modality. I don't know if this patient, it depends in a setup where a patient is financially draining themselves for chemotherapy and stuff. This is also financial toxicity. So maybe letting a patient's family members know that you have done the best you can. This is one of those situations where it seems like we have used, I'm also noticing a word that you used, we lost the patient. We lost the battle. We use metaphors of war for health and life and death, which is a journey. It's not a battle. There are no winners and losers. There are only journeymen, and we travel together with them. So this is a complete reframing in our mind that we need to take on. So if I look at it, life is a journey. Cancer and these illnesses are terrible mountains which we have to climb, and there are storms that hit us, and sometimes there's a deep crevasse that we fall into, and sometimes we have to come all the way down and make our way around, and we are just like those Sherpas who help people reach their goal. So there is no winning and losing. In this situation, all we can do is try and be as honest with the patient and address their symptoms. We don't know what this patient would have wished for the end of their life. We don't know what the family would have wished for. So I think fundamentally the part which we could have done as a pulmonologist is to offer more breathlessness support. And I don't know if there was a palliative medicine team here, but that is what would have really helped. What palliative, as a pulmonologist, the main focus would be pleural effusion, breathlessness support with making sure morphine is adequate. That's all you can do, because this patient could have multiple ways of involvement of the lungs. The decision for intubation and ventilation also is something as a pulmonologist we can say. If it comes to this patient is in shock, I would recommend intubation and ventilation would not be beneficial. So continue non-invasive supports. See, for the patient family, if it's all happening so suddenly, maybe being in the ICU, being on maximum non-invasive measures is also comfort that we did the best for our patient. So that's sort of where I would think we could have slightly different in terms of the management. Very, very challenging.
Madam,
Actually,
can I say a little sentence also?
Sure.
Madam, from the case discussion, what I thought it was rather a more aggressive treatment approach rather than a palliative approach. So it becomes difficult in emergency situation when patient comes into the ER, whether the patient is to be given to palliative physician or to give it to a pulmonologist. Because pulmonologists would try to go for an aggressive management, where in this case, it could be a futile exercise for them. And there is no role of there is no reference to a palliative physician is done in such cases, because in a young age, in an emergency situation, usually it is a pulmonologist or an intensivist will tackle the case where if they don't have a palliative exposure, this is the situation will happen, because after cardiac arrest, in such a case where there is a severe metastasis all around the body, after a arrest, otherwise if a palliative physician would never think of intubating the patient. So I think it was in a case, it is an aggressive treatment approach rather than a palliative.
No, sir, I will, Dr. Pandya, point well taken. In a 30-year-old with Ewing sarcoma, where the family is yet to come to terms with the non-response to treatment and progressive disease, I think the patient is well within, it's perfectly justified to be pursuing palliative chemotherapy or anything possible to buy as much time as possible. The part that I'm saying is that this isn't exactly patient came into the emergency room and arrested. This is a progression of 1 or 2 days. The patient was on noradrenaline support. Now, what you were saying about there being a palliative medicine service, we don't have enough palliative medicine services across the country, which is why we have pulmonologists being trained in a palliative medicine approach, which is why we have palliative care integrated into ICUs. If this patient came into my emergency room, our chief of ICU would not intubate this patient. He would have the discussion of non-escalation of care and ceiling of care. So this is not just training that pulmonologists need to have, it's intensivists, it's cardiologists, it's neurologists, it's neurosurgeons. When it is non-beneficial treatment, as much as possible, if we have the family on board. So it is to be offered. I don't know if the opportunity for a conversation was taken. You remember a slide that I showed you earlier on of different points in the trajectory, in the dip. This is an opportunity for conversation. This is an opportunity for conversation. There are multiple opportunities for conversation about advanced care directives, ceiling of care, and withholding life-sustaining treatment in a patient's trajectory, whether it is a 2-month history or a 2-year history. Are those opportunities taken? And do we have the training to have that conversation in a sensitive manner? As I said, I'm not going to project on any of my beliefs and values. If the patient's family still was do everything possible, do CPR, absolutely do it. Because they must not live with the trauma that we didn't do the best for our loved. So if the conversation hadn't been had, everything you did, Dr. Shrija, was perfectly right. The only thing I have to suggest is, did we miss an opportunity for a conversation earlier? That's all.
One more minute, can I take?
Please, Dr. Shrija, yes.
Yeah, we have spoke to his wife. His wife, as it was, she was unable to take it. She told like, we'll go with all the life supports, like we'll go with the CPR and the mechanical ventilations. Everything I have explained to her, and she was willing for the support. She was like, till the last moment, whatever the thing will be able to take it, just go with that. That was it.
Yeah. Absolutely. Ma'am, I am telling you, 30-year-old young man in this situation, the wife choosing this, it's perfectly justified. So it's just the opportunities for conversation, were they taken? That's the only question. If the conversation was taken and the patient's wife, this is important. Because as we said, that statement, we'll go back to the way we die lives on in the memories of those we leave behind. For this wife, it was important that she did everything possible. Just as we have this metaphor of battle and fight, my dad's a fighter, my sister's a fighter. The general public has this. We have only created it. We in medicine have created it. It is up to us to change that metaphor to one of journeys, not of battles. Thoughts and questions? I'll just see if there are questions up in the side box as well. So,
Ma'am, so we have one question from Dr. Sonali. So she's asking, for palliative sedation, do we include both midazolam and morphine together?
So depends on what your goal in palliative sedation is. If you have only breathlessness, then you could work with just morphine. And if that is enough to bring down breathlessness with a little bit of sedation, that's fine. Patients, as I mentioned, can get agitated also. There can be hypoxia, dyselectrolytemia. There might be all kinds of things which make them agitated. If you also have agitation, then I would definitely add midazolam as well. And you can use both together. You can use an infusion, which is morphine, as well as midazolam together. Both are perfectly fine. There's a question, how does end-of-life care happen in a rural facility with limited facilities and with caregivers unable to understand the implications? Any Indian studies? So, actually end-of-life care happens much easier in rural settings because their financial distress is so high that they cannot possibly even think of intensive care settings and life-sustaining treatments. So there, when you tell a patient that disease is progressing despite treatment, the more common answer you will find is, let us just take him home, let us just take her home. In fact, patients refuse admission in rural health settings. It is difficult for us even to admit a patient, even if we say it is something reversible like a pneumonia. You could have a patient with a cancer who comes in with a pneumonia into a primary health center, and you'll say 2 days admission, IV antibiotics and oxygen, and you can go home. They'll be like, no, we will just take home to die, which is what happened in COVID all across India, by the way. In the rural setup, majority of people just went home to die. Yes, the worst part of it, they died at home with family, but sadly without opioids, without symptom management. So in a rural setup, death happens more at home. In a rural setup, people typically prefer home being the place of death because rituals are important to them. Grieving as a community is important to them. The process of bereavement cannot take place for them in a district hospital. So when you are in a primary health center, CHC, district hospital level, and you tell the patient that they're going down, or you tell the patient's family that they need ICU, and they realize that this is worsening, more often than not, they'll say, if it is going that way, we will just go home, because it is important for us to be with our entire family, with our clan, with our community when death happens. So it is a more death accepting society community. Rural communities are more death accepting. Urban nuclear families are death denying. Think about it. I have people who in their mid 40s or mid 50s have never witnessed a single death in their life. In a rural community, they witness death because there are more intergenerational families. There are more animals who die around them. So they witness death, grief, bereavement a lot more and are emotionally, socially better prepared for it. The only problem is it happens without symptom management. In states like Kerala and Telangana, they have addressed this by making morphine available in all primary health, in most primary health settings, and home hospice care available as well. And the hope would be that all states across India take that model forward. So Indian studies about quality of deaths in rural India, I'm not really sure. One of the problems with deaths in rural India is that nobody knows the mode of death. So in fact, even our epidemiological data of what is the cause of death in India, we do it through a process which is called narrative autopsies, where people die in their home in rural India, and the death is recorded always as one sudden cardiac death. So primary health center doctors and epidemiologists and community medicine doctors go to patients' homes and sit with the person who was with them for 3 days before they died. Then what happened? Then what happened? Then he stopped eating. Then he suddenly clutched his chest. Then this happened. Must be an MI. Oh, then suddenly this happened and they had a seizure. It must be this. That is how we track down how people are dying in India. So that's how we know that this belief that rural India doesn't have hypertension and has a lower incidence of stroke is actually completely wrong. We have a very high incidence of hypertension, cardiovascular mortality, and stroke in India. So rural India is a completely different ballgame. Yeah. Next question is DNR, is it legal in India now for such patients? Okay. So DNR, I can send you the documents on this. There are 3 papers that I will share with you. One is the ICMR position statement on DNR, which is that if a patient has already arrested once, then you can declare, or is already on inotropes and support, then that patient, if there is no potential reversible, may be declared DNR, and it is legal because it is an ICMR position. But that is in the context of acute critical illness, worsening with multi-organ failure. And in the context of not in that setting, advanced care planning and advanced directives are now available and legal in India. There was in 2018 the right to privacy, along with that end of life care framework for advanced care planning and advanced directives and withdrawal of life support. That was a very messy procedure which required a judicial magistrate first class, a primary medical board, a secondary medical board, a judicial magistrate first class actually coming and seeing and then saying this patient may die, which would take 2 weeks to do withdrawal of life support in an ICU, which would bankrupt a patient's family. Now, it is just information that needs to be given. So primary medical board within the hospital, secondary medical board, which includes the district medical officer and appointed medical officer, that turnaround time has been reduced to about 4 days. So 48 hours for each. Includes 1 person who's the patient's treating physician, 2 others who are not directly involved in the care of the patient from the hospital level. And we only need to inform the judicial magistrate first class. So there is a legal process that is set up. Even now, the majority of cities and districts do not have the appointed person and the ledger, but the process has been laid down. In all of this, the most important thing, 1, has the patient previously expressed their wish and it is known to everyone and documented? Second, that there is no conflict within the family. Every next of kin person is on board that withdrawal of life support as the surrogate decision making is the right thing to do. Only if I have complete pan-family consensus, then we can go ahead with this. And it's perfectly justified. One thing I will say, when I document for withdrawal of life support and when I document for withholding life supporting treatment, words are important. I don't write patient was told about need for intubation and family refuses it, and then you make them sign it. Can you imagine a daughter who has to sign, I refused to do this for my father, and later on she'll live with that guilt. I write, patient's clinical condition was discussed with the family, non-reversible progressive illness, multi-organ failure, imminent death. Intubation, ventilation, life-sustaining measures would not offer any curative benefit to the patient and may place additional symptom burden on the patient. Based on shared decision-making, the choice is to proceed with best supportive care. No escalation of care, stealing of care, ICU, non-invasive, or no ICU, only ward, whatever, no tube feeds, no IV fluids. This is shared decision making. I'm not giving any blame to anybody. You are refusing. It is your responsibility. Don't hold the hospital responsible. I am a doctor. I support your medical decision. This is a sound medical decision. It's shared decision making. So the words we choose are important. I think that's the end of questions.
Yes, ma'am. There are no more questions in the chat box.
I will share these documents with you. There's a latest guideline of Indian Society of Critical Care Medicine with Indian Association of Palliative Care, which is for specific to palliative and end-of-life care in ICUs. So Dr. Pandya, to address your concern, we are doing a huge focus on educating intensivists around the country, because we really should not have people dying on life support, because that's inappropriate utilization of services and also denying the patient and the family the opportunity for a dignified and a more peaceful death, right? That's sort of what we're trying to do.
Madam, just wanted to discuss a little bit on what you said in your session the last, DNR and DNI, and still to continue into the ICU.
Yeah.
Won't it be better once there is a DNR and DNI, can we shift it patient to the ward with the relatives? It would be better rather than keeping into the ICU.
So, sir, I absolutely agree with you. I'll give you two scenarios. So one is patient's multiple scenarios actually. One is patient is DNR, DNI, but is on pressors or requires high flow nasal cannula, which my hospital does not allow me to continue in the ward. And there is a child who has just boarded a flight from USA and will take 36 hours to reach India. Stay in the ICU, right? Because there is a goal here of this child to meet their dying parent. So for that, I will do it. Second is sometimes, and again, I'm telling you that, as palliative medicine, we have a responsibility to caregivers too. Families unable to witness what is happening. They do not have, at that point, their emotional and mental health will not allow them to witness the death of the person. And they request that please keep in the ICU for another day or so. Let it happen in the ICU where you are taking care. I cannot be there. In that case also, as long as there is no pressure for an ICU bed, there is another patient who has a reversible situation, who wants the ICU bed, who needs the ICU bed, I will sometimes allow that to happen. So that allows me to address the caregiver and survivors. That's where we do it.
So it is case to case basis.
It is. It is about the goals of care for patient and caregiver. I agree with you. If the patient is DNR, no, again, I will not make a blanket statement of DNR means no ICU, because I could have a reversible situation like an acute pulmonary embolism in a patient who's on palliative chemotherapy, but they are DNR, but I can go thrombolize them in the ICU. I can put them on pressor support for 2 days, put them on high flow nasal cannula, then they'll reverse and they'll live on for 1 more month. Or 2 more months. It's the patient's goals of care. DNR does not mean no ICU care. DNR only means if I arrest, do not resuscitate. Up to the point of arrest, do the best you can. Buy me whatever time with quality of life.
Okay,
each patient sets the goal.
Yeah, thank you.
So these 3 scenarios will allow to. In what sometimes they call code. Yes, Dr. Sonali, very good point. I instruct all the nurses. We have an end-of-life care plan in the ward. So when the patient comes to the ward from the ICU, we stick first thing on the chart of the patient is this patient is on an end-of-life care plan, which means no code will be called. And what that stuff I said, no, I may not be at the bedside, but the nurse, the duty doctor, everybody knows to be quiet and calm when the bradycardia happens, when the flatline happens, to be gentle, to tell the family in a compassionate manner that yes, this patient has now passed.
Thank you so much, ma'am. Um,
Thank you, Dr. Hashmi.
yeah, I think there are no more questions in the chat, and I couldn't see anyone raising their hand too. If so, I think we can close with the session for today. Yeah. Thank you
Thank
so
you.
much, ma'am, for such a wonderful session. It was really nice hearing to you about end of life care, hearing you speak about end of life care, because it is always nice to hear different people speak about end of life care. And I love hearing it every time. Thank you so much, ma'am, for such a
It
wonderful
is an
session.
honor that we have, isn't it, Dr. Hashmat? You know, the amount of care and preparation that we take for the arrival of a baby, the amount
Yeah,
of care we provide to an expecting young mother and the family which is expecting a baby, there should be the same amount of care and attention to a life, to a person who's leaving us.
definitely, ma'am. Totally agree with that point. Thank you, ma'am.
Thank you all. Have
Yeah,
a great evening. Bye-bye.
thank you. Over to you,
Thank you,
Sandeep.
ma'am, for the wonderful presentation. Thank you, Dr. Hashmant, for facilitating the session. Thank you, and Dr. Srija Reddy for the wonderful case presentation. Thank you all for joining the sessions. Thank you. Let's see you in the next sessions. Bye.